helpful to know what roles you're in at the moment. So if you can post either your name and email or your job role in the chat, that would be super. I think we've got your mics and cameras disabled for now, but they will be available because we want this to be a discussion. And we'd love you to ask questions too. So if anything comes into your head while Steve is presenting or whilst we're having discussion, please post that into the chat and we'll make sure that we come back to that at the end. Before I hand you over to Dr. Steve Letton and Dr. Tim Cooper to introduce themselves, they're both very experienced GPs and healthcare leaders. I just think it's worth pointing out that in our various conversations, we're all passionate about using digital solutions to support patients and yourselves as providers, but we feel that the long-term condition agenda has been somewhat overshadowed in recent years. So today is really about understanding where we both sit as organisations within the space of providers, commissioners and product suppliers. So this is us, Redmore Health. Those of you who know us, we're helping in a number of areas to interpret policy, to understand what the provider landscape may look like. Many of our team have got practice backgrounds, and we also operate as training and coaches, along with working closely with tech suppliers to optimise spreading the use of their products. I'm just going to pass you over to Tim to describe Severa's role here.
Thanks, Lisa. It's really nice to see everyone. I'm Tim Cooper, so I'm a GP. I'm a partner just outside Basingstoke. I'm also medical director at Severa. So Severa works alongside practices, PCNs and ICBs to deliver proactive virtual care, particularly around sort of long-term conditions, things like asthma, high blood pressure, cholesterol. We've got a combination of technology which enables automated and smart recall, and then a care team at the other end to help you manage patients to target. Thanks, Lisa.
Thanks, Tim. Thank you. So in terms of context for today, there's numerous papers, planning guidance and different models of care out there at the moment. We're all aware of the current pressures in general practice. We understand the increased demand, and it's not just due to winter pressures. We know that there are workforce issues and that there's also a tension between staying afloat and the need or desire for transformation. But I guess we all feel that the priority focus in the NHS, even the wider political and general press over the last few years, has all been about access to general practice. And whilst access is clearly important, that doesn't mean that it needs to be to the detriment of long-term condition management. So access for people with long-term condition management is really equally important, as they both have needs for on the day and planned care. So we feel it's an equal and not a lower priority. And there is plenty of evidence available to show that continuity of care leads to better outcomes. Yet some of those digital solutions that prioritise access can either disrupt or hinder that because they don't foster either relational care or team-based care. And only yesterday we were having a look through the digital buying catalogue to see what solutions were available to support with either population health or long-term condition management. And they're really only presenting the two main clinical systems at this point. So we know that there's some great suppliers out there with products, and we're hoping to be able to showcase some of those newer tools throughout this series of events to help you think differently. And I think that's because, although it is complex, it's really worth doing better. We know that long-term condition management is way more than just delivering quaff. This was my little brain dump. And really what I wanted to say is what we're talking about today cuts across the whole population care delivery and communication models. So we're hopefully going to break some of this down into manageable chunks for you throughout the next couple of months' events. And today we're going to start with the big picture view, and Steve is going to take us through population health management. So I'm going to hand you over to Steve now. For the rest of the session, we'll come back on at the end just for a chat.
Thanks very much, Lisa, and hi to everyone. Hopefully you can hear me okay. Let me know if you can't. And sorry, I'm a bit silhouetted. That's probably not a bad thing for you all. So I am a practicing GP like Tim. I've also got a public health background. So I was a public health consultant for a while. I think we've got a screen share. Okay, it's gone now. Yeah, excuse me. There's a screen share in the window.
Sorry, Steve.
See, Lisa, I don't
there
know
you go. Thank you.
Thank you. So yeah, so what I'll be putting forward is a population health management view of care delivery, in particular of primary care. And it very much comes, as Lisa says, as a high level overview, and we're not going to get deeply analytical. We're going to focus very much on the practical aspects of population health management, and I'm hoping that will be helpful conceptually and practically to delivery of primary care with the digital solutions that Lisa has mentioned. So if we go to the next slide, please. So having lived through multiple NHS reconfigurations, as many of you probably have as well, the NHS, in my view, really gets it fundamentally wrong when it thinks about care system redesign. Because what it takes, and it's, I suppose, understandable in terms of where, you know, the Department of Health and NHS England are coming from, is it takes very much a managerial perspective of care system redesign. So it starts thinking about organisational form. Now we've got ICBs and ICSs and places and primary care networks, which I think are a good thing. And there's lots of talk about future GP contracts. There's R's funding, and the R's are under number 3. They're a new role, although described as a funding system, which is interesting in itself. And then ultimately we may come to, well, what's the focus? What are the biggest problems we want to fix? And Lisa's talked about same-day demand. But there's lots of other challenges, such as long-term condition management and prevention and managing people with complex needs. So the next slide shows what I think is a healthier approach. And I think this is what businesses would do. Businesses would take very much a customer focus. Steve Jobs, a bit of a hero of mine, always used to say, start with the customer experience, not the technology. So, and as clinicians and people working in the NHS, I'm sure we would want to start with the needs of our patients and our communities. So start with a focus, start with a problem you're wanting to fix. Then think about what are the care functions that you need to support that area of focus. So if you were focusing on frailty, older people with frailty, which would be a reasonable thing to focus on, we then think about, well, we want the function of a structured medication review, of a care and support plan, of health coaching, of carer support. And then you might think about what roles might be utilised to fulfil those functions. And then you would think about, okay, well, that's the focus, that's the clinical model. How are we going to fund it? How are we going to incentivise it? And what, if any, organisational forms are required for that? I feel personally that often new organisational forms aren't necessarily required, but teams are required, and those teams can be made up of individuals from different organisations. Population health management is very much about the personalisation of care at the community level. You know your communities, but a community is made up of lots of different types of people. So you then need to think about cohorts of people. And then you need to, of course, think about the needs and preferences of every unique citizen or human being in front of you. So there's at least 3 levels of which we need to personalise care. And I think that's where population health management comes in, particularly at number 2. I think other agencies probably know more about the needs of the community, such as the local authority, families and people and clinicians know about individuals, but not many people seem to think about the cohort, and that's what today is mainly about. Just a few slides because I want to leave lots of time for discussion. So if we move on to the next slide, and this is my simple definition of what population health management is. There are lots of definitions out there, but none of them quite work for me. And actually, there's a little bit I've missed in this. So my definition is population health management is about identifying, that's the bit I missed, apologies, about identifying and managing groups of people with similar needs. And I think probably frailty is a really good example. Others would be multimorbidity. Another would be, as Lisa said, people with individual long-term conditions such as asthma or diabetes or hypertension, whatever it may be, or a cluster of conditions, or lots and lots of conditions, or complex needs, which we'll come to. So population health management is about identifying and managing groups of people with similar needs. And the sort of philosophy behind this, which is one of the reasons I'm attracted to population health management, is it's recognizing that there's not a single care model to meet the needs of a population. Because if you think about people with frailty, they require quite a different approach from, I imagine I'll be speaking to a patient this afternoon who's generally well and has got a urine infection or tonsillitis. Those two needs and those two models of care are going to be quite different into how their needs are met. When somebody with complex needs, with frailty, with dementia, end of life has a crisis, that requires a rather different approach than a generally well young person with a simple infection. Okay, next slide. It's worth drawing a distinction with public health. So public health is about the whole population as a whole, and interventions tend to be ones that affect the whole population. So we think about education and employment and clean water and availability of good food and green spaces. Whereas population health management, as I mentioned, is about groups of people with similar needs, but it is about the whole person. So population health management is at the cohort and individual level, but it thinks about their holistic needs, not just one of their long-term conditions, but all of their needs, including their social determinants of health, such as their housing, their employment, their social situation, etc. Okay, so let's get on and talk about segmentation if we move on to the next slide. So segmentation is literally how we create segments. If you think about a grapefruit or an orange, and there's segments of the fruit, there are segments of the population. But the difference with fruit is each segment is different in population health management, both in terms of how it looks and the number of people in it, and how you would look after them. So some care models, some segmentation models rather, are just focused on diseases. So you think about asthma or you think about diabetes, but often that's not the whole needs of an individual, and often people have more than one disease, so that doesn't really work. Some people think about segments of the population who are receiving hospital care or primary care or social care, or people just think about risk. So we're just going to take the top 5% of risk of hospital admission. But the problem is that could include premature babies who are at risk of respiratory infections and being readmitted to pediatric intensive care or special care, or older people at risk of being admitted at the end of life. So that doesn't quite work either. So segmentation, which needs to be distinguished from risk stratification, segmentation needs to be holistic, and it needs to think about all the needs of individuals. So the next slide shows a model that I created with a GP colleague of mine, Mark Davies, when I had the fortune of working for the National Association of Primary Care around the development of primary care home, later becoming primary care networks. So what Mark and I did here is we basically said there's three big life forces: children and young people who have their own needs and preferences, their own settings, such as schools and university and places of apprenticeships, working age adults, who by definition are likely to be at work a lot of the working week, although we have rather worrying numbers of working age adults who are economically inactive at the moment, often with significant and often complex medical needs, and then older people who are quite often retired or semi-retired. They might not be, but they are older, and because of that, they're likely to have different needs and preferences. And then, because we're luckily not just defined by our age, there's also the columns about whether people are generally well currently, as in they have no ongoing long-term condition. We'd expect that number from our experience in general practice to be quite small, but it's actually the majority of the population don't have any QOF conditions. Using QOF probably is a bit of an underestimate, but I think at least half the population are generally well with no long-term condition. They may have risk factors for developing a long-term condition, but currently they're not on a disease management program. People with long-term conditions, and then people with complex needs, by which I mean a mixture of physical health problems and mental health problems, or a long-term condition and a disability. So people with learning disability and asthma, or learning disability and diabetes, or dementia and heart failure, or bipolar disorder and diabetes would be under that column. Because I think it's not just the number of physical long-term conditions that creates complexity of need and management, it's when you get a mixture of physical health problems and mental health problems, or a long-term condition with a disability. So we'll go on to the next slide. You can then subdivide the columns as to whether people have a risk factor for a long-term condition, but don't have a long-term condition yet. And the primary care clinical record is awash with long-term condition risk factors. Not all of them, but obesity, pre-diabetes, smoking, etc. There was a hand up which has gone down now, but please do pop in the chat if there's any questions, and I'll try and have a little look as I go along. But I suppose the question is, do we routinely look at those risk factors in the generally well population and identify people with one or more risk factors and proactively look to support them in a preventative way? I think a lot of practices do, but maybe not all. Thank you, Colin, for your note. We can subdivide long-term conditions in single or multiple, and we can subdivide complexity of need into whether it's physical and mental health problems or whether it's long-term condition and a functional impairment. I mean, this is one model of segmentation. I quite like it, probably not just because I invented it, but because it's quite simple. It's starts as a 3x3. You can then have a 3x6. You could have a 6x6 if you subdivided the age courses. It's a start, and you can get more and more granular within the cells. If we go on to the next slide, so this isn't just a philosophical framework. This is actually, in order to understand your practice population or your PCN population or your place or your ICB, understand the proportions of people with different needs, and then potentially looking to focus in, as I said at the beginning, to focus in on older people with complex needs, on children and young people with complex needs, on people who are generally well with a risk factor for long-term conditions, wherever your focus might be. But I think Lisa is right, 24%, and that's pretty static wherever you look. So at least a quarter of the population have long-term conditions. Have we got really good proactive models of care wrapped around those groups of people with typical clusters of conditions And have we got the best way of identifying them and managing them? I think probably not. So a lot of people are generally well, but quite a lot of risk factors. About a quarter have long-term conditions, and a relatively small proportion have complex needs, but they make up about 70% of the occupied beds in a hospital, and they consume a lot of primary care and lots of other services. So if we move on to the next slide, and this is sort of the tail end of my talk, but this is probably the most important slide, and I think this is the one I'd really like some feedback on, and to see, you know, this segmented approach to care model delivery in primary care is helpful or not. And when I say in primary care, I don't just mean general practice, and I probably don't just mean primary care. I mean primary and community and social care and mental health care and third sector support, and also bringing in specialist expertise from the hospital too. So I think, and what I've done here, I've substituted the live quarters, because in general practice, we take very much an all age approach, don't we? We see anyone who comes from 0 to 100 and whatever we had the other day. So I think there's 4 big care models. So you've got the generally well, long-term conditions, complex needs, and then you've got primary prevention, preventing the development of a long-term condition, ongoing care, the management of a long-term condition or more than one, and then reactive care, acute care, same-day demand, whatever you call it. Somebody has a new concern or an exacerbation of an existing concern, and they quite reasonably want some support at that time. So the 4 big colours. We do actually a lot of primary prevention in primary care in general practice. We vaccinate, we screen, we do health checks, we give brief advice for smoking cessation, we provide smoking cessation services, etc., etc. Long-term condition management makes up a lot of what we do. And I've wrapped primary prevention in that, because I think if you're supporting somebody with their hypertension, you'd probably want to also make sure they're having all of the preventative services. If you're managing somebody with asthma, you want to make sure they've had a influenza vaccine and a COVID vaccine, and you'd certainly want them to stop smoking, which is only going to be helpful for their asthma. It's going to be helpful for their cancer risk and cardiovascular disease risk. So that's a second model, the orange colour. And then people with complex needs, where I think a comprehensive, holistic model of care is the right one, where we're managing all their long-term condition needs, but we're also trying to prevent them getting new conditions, and we're responding to crises. And in the top column, this is often quite controversial, because often GP colleagues say to me, well, everyone needs continuity. And I understand that argument, but I think there are a group of people in the population that absolutely must have a high degree of continuity. And I would argue that there are other groups where that is less of a priority. Maybe nice to have, and sometimes episodic continuity is really helpful, in fact often it is. But here I'm talking about relational, ongoing, really high degree of continuity. So the only person who responds to a crisis for that individual is somebody who knows them really well. Difficult to bring into action, but possible and really important. And then you've got the pink colour, which is the same day demand for people who are not complex, where continuity is less important, but rapid access is. So I'm going to finish off with the last few slides and a couple of examples, but I won't dwell on them, but we can go back to them. So if we go to the next slide, this is just a reminder of what we've gone through, but in text, because some people, I'm very visual, but not everybody is. So you've got 2 types of reactive care at a high level. You've got responding to people with non-complex needs, an exacerbation of asthma, a urine infection, cellulitis, an ear infection, but people who are not too complex. And then you've got reactive care for people who are complex, whereas I've said I think continuity is really important. And then you've got 4 models of proactive care where you're not waiting for people to call, you're reaching out to them. You're delivering primary prevention, you're managing single long-term conditions, you're managing multiple long-term conditions, and you're proactively managing people with complex needs. So a couple of slides of examples. So this is Foundry in Lewes. When I went to visit them in the days of primary care home and met the wonderful Phil Vallick in Lewes in Sussex, which is also a nice place. There were 3 practices, and Phil really liked my 3x3 model and decided to create a care delivery system around it. They eventually became a single PCN practice. And what they did is they developed an acute care team for the non-complex acute needs. They developed a disease prevention team. They developed a long-term condition team, and they created 3 different complex needs teams. People don't stay in one team forever, so it doesn't mean that people can't rotate round. But I also think different GPs have different interests and expertise, and maybe we could give more GPs and other clinicians the opportunity to do a bit more of the things that they like and a bit more of the things that they're good at. So from my perspective, I like acute care. I'm not as clinically interested in long-term condition management, although I'm interested in the different models that could be applied. And I would be very happy in the 3 sessions a week I do in general practice to just do acute care, triage and seeing people face to face, and pass people on for their long-term condition management, disease prevention. And I just don't think I'm in the practice enough to provide the continuity for the people with complex needs. So Phil developed this team, I think 3 teams really: acute care team, ongoing care management, and complex needs teams. Okay, and if we move on to the next slide, another model, and this is just looking at people with complex needs. This is a company I work with called HN, or Health Navigator. They use machine learning to identify on the left-hand side, the 5% of the hospital population who consume 71% of the occupied bed days in that year, which is quite a phenomenal Pareto relationship. The next bit, I mean, I didn't realize that was as big as that, and that is huge. What I didn't know is how transient that 5% is. So if you look a year later, the 5% who consumed the 71% of occupied bed days the year before, in year 2, on the right-hand side graph, in year 2, only 14% of that 5% are still in the top 5 consumers. 2% have died, 20% still consuming activity, but less so. 64% no activity consumption. Probably because in year 1 they had a crisis and things resolved. And because of this regression to the mean, this is why you can't just do a sort of time series analysis, say, well, we managed this group of people, the next year they were hardly consuming any care, so our care model works. You've got to do a randomized controlled trial, and these guys did that. So if you go to the next slide, they did a health coaching model, and compared to the control, they reduced non-elective activity, elective activity, A&E activity, improved patient activation, improved general health, and on the last slide, it didn't create any increase in primary care activity. And that was through a virtual health coaching model that pulled together a team of people to manage those groups of people with complex needs. So that's the model, that's the approach. those are the different care models from the segmentation model. Those are some examples, and I've purposely left us lots of good time to have a chat. So I'll let Lisa and Tim. Well, I think Lisa's the MC, so I'll let Lisa bring us to order and take any questions.
Thank you, Steve. That was really helpful. Loads of stuff jumping out at me there. I think your definitions are really important. The difference between public health and population health management, because I sometimes think people get confused between those two things. The same with it being very different from risk stratification. I can see we've got a hand up there. So if you want to come on camera and mic, we can open you up. That'll be fine. I'm going to take these slides down now so that we're all just here to chat with you. Bear with me whilst I find Teams, which doesn't want to stop sharing. You see all my rubbish. Apologies.
My friend Michael there. We can't have a physical hug today, Michael. So a virtual.
There you go, Michael. Fire away.
Virtual hug. Steve, always good to see you, colleagues. Lovely to connect in this really important matter. The thorny issue of population health deserves these deep dives. And I personally believe it's likely to be team primary care that has to come up with the solution of this. And of course, general practice is at the heart of it. But Steve, you and I in NAPC back in the day and subsequently have talked about the need for the wider team primary care to mobilise around the grid, if you like. There are many missions that community pharmacy could go on now, and in our discussions about a contract of the future would like to step in and up to, so that we help and support this sacred duty that we have, and to augment and enable general practice to deliver. I just don't think you can do it all on your own, folks, in general practice. I think you need community pharmacy's contract to align to this mission. Steve, you still hold that to be a philosophical tenet, don't you?
I certainly do. You guessed correctly. So I'm focused on the needs of the population and trying to make sense of their needs in a way that people can use, and then describing at a generic way how we need to support people with different needs. I am completely agnostic as to what people, professionals or otherwise, or organisations support those people. So just to use long-term conditions as an example, and putting forward a bit of my biases, I don't think I'm very good at long-term condition management. It's just a bit too complicated for me. I'm not very good at following a pro forma or a guideline, and I struggle with keeping up to date with all the latest medical management of different conditions. But I know some bloody good clinical pharmacists, and I know some bloody good specialist nurses and coaches. Mm-hmm. I would, if we're talking about professionals, I would see GPs having a day-to-day, a pretty minimal role in long-term condition management, but to come in maybe where there's a diagnostic query, where there's maybe some complex medicine management query that they, for whatever reason, have a little bit more knowledge on something. But I would have the core of the team in long-term condition management as a nurse specialist, a clinical pharmacist, and a health coach. In terms of community pharmacy, they're clearly critically important in the long-term condition management. But I suppose it's then a question back to clinical pharmacy. Where do you see your sweet spot is? Is it in acute care and same-day demand? Is it in chronic disease management? Is it in prevention? Is it in managing people with complex needs? There might be some areas where community pharmacy lends itself more to the challenges than other areas.
Yeah. Steve, wise words. I thank you for them, and I think you're spot on right. I think there are a basket of sweet spots in various places. When you add them together, add up to our meaningful mission and a supportive contract. So I don't think it's one or t'other, but it's certainly, we need connectivity of care as well as that continuity of care. So what we do and how it connects into that macro grid, I think, is the critical factor. And I look forward to exploring that later and further with you and others,
You too.
Steve.
Keep in touch. Cheers.
Thank you, Tim. Go ahead.
Thanks, both. Yeah, no, it's just a really good conversation. Thank you, Michael, for kind of bringing that reflection from pharmacy. And I guess one of the things I'm hearing quite clearly from Steve is that there's been an evolution and a development of primary care over that period. So if you go back to sort of primary care homes, that initiation of working at scale, looking at populations towards PCNs, which we've all just lived through as a contract, and potentially, dare I say, things like integrated neighbourhood teams as possibly the next phase of where we get to. I think what it probably tells me, and I previously used to work within an ICB, is there's a shift towards that kind of population health, that understanding, but actually in practice it can be really quite tricky to implement. And I wondered whether colleagues, just looking through the kind of people we have on the call at the moment, working in your different spheres, whether you're in sort of a PCM, whether you're in an ICB, whether you're from a public health background, has anyone got some great experience of where they're starting to move that towards neighbourhood care, where they are starting to actually change the care delivery model? Because I think that would be great to explore how that's working, what enabled you to get where you wanted to, but importantly, what sort of tools, information do you need, I guess, to help support you in that conversation? Because I know certainly that's where colleagues like Lisa, myself, we're trying to sort of work alongside you to try and understand exactly what's best, really. So I'd be really grateful if anyone has any kind of examples of where they're starting to change the care model they feel able to share.
This is where we have to pause for a moment for somebody to think about the answer to that one, Tim. This is quite a challenge. And I'll just fill while people are doing that. So I had a conversation a while ago with a couple of PCN leaders and Professor Donna Hall. Don't know if I'm sure most of you know Donna, who's looking at neighbourhood teams and really understanding the overlap between the local authority, all of the other services involved. And the conversation I was having with her was around data sharing agreements, because one of the fundamental problems that we often have is we've got siloed information, and we're probably all managing the same patients, but from a different lens. And Donna said, we just got in a room, a group of people just got in a room and said, who's on your caseload? And she said the same patients were on all of our caseloads. We didn't worry about systems and funding models and the forms of organisations. We just said, what can we do for these people here collectively? And the answers came out of the room. So, I thought it was a different approach. And sometimes we get bogged down with the governance around managing care across siloed organisations instead of understanding that these people need help and they're impacting on all of our services.
I remember very clearly, Lisa, the beginning of when we first had the PCN DES, going back to that very first days when we were all given that relatively loose document. One of the things that always struck me was who was expected to be sort of at the table with you. So when you were working your PCNs, there was a very clear ask to have community pharmacy, voluntary local groups. And I think there was a planned sort of escalation in terms of their engagement with us in primary care, but obviously pandemic has ever kind of got in the way. And I think that's one of the, certainly one of the great challenges of systems is how you utilise that great activity that's happening outside of primary care's front door. Understanding that touch points in the community are different for everybody. And actually there are places that exist within the community where people are going regularly. So we did lots of work during the pandemic around different experience for vaccinations, about where things take place, and we ended up running a shopping centre for the best part of a year. And I guess for me, what those experiences taught me is that actually healthcare and the way people consume healthcare can potentially look different to the traditional model of access that we've got right now, where we're sort of funneling everyone into a primary care setting. The challenge, as always, is knowing which population groups are we going to target or think creatively and think differently with. So, Steve, in your point there, you mentioned around things like vaccinations and elements like that. Where the predominant population that we're serving, for the most part, tend to be sort of either younger patients or older patients. And again, I've always reflected that I think there's opportunity in that space to do things differently. But again, you need to do it at a scale that makes it meaningful and worthwhile, which is why I've always enjoyed doing things at scale with our PCN, precisely for that reason.
Thanks, Tim. I'm just not sure if there's any other questions. I can't see on my Somebody's posed a question, how do you balance the top-down segmentation from an ICS of population health management with the on-the-ground requirements of the primary care teams? That's a good question. Again, who's driving the agenda? Is it the people that are responsible for the health of that population, or is it the people who are providing the services? It's a difficult one to answer that quickly. I think most practices...
It depends why you're doing it, really, doesn't it, I suppose, Lisa? Because, I mean, I don't imagine the ICS will be doing segmentation because it doesn't really make sense for them. They're not going to be delivering many services to population segments. So what you'll probably get more from the ICS is public health data, which gives you a sense of the priorities in different areas, but it does nothing to tell you who. It tells you what, but not who. You can't identify individuals and know all the different needs of a group or an individual person. So I think the ICS there is to provide strategic focus and support, but it's down to providers, and the ICS isn't a provider, it's a commissioner, strategic commissioner, convener. It's down to primary care, as Tim said, to decide what are the care models that are better delivered at scale, a scale greater than individual general practice. I don't think I've got all the answers to that, but I think vaccination is a good example. Screening is a good example. I think actually long-term condition management could be delivered at scale. But unless you start to, so there's lots of talk about integrated neighbourhood teams, but I've not heard any really good description about what they're for. What are you going to do with your integrated neighbourhood team? Why do you need one? And I think if you get into that and you start somewhere, whether it's around frailty or end of life or e-consultation hubs or acute care hubs or long-term condition management at scale, you know, talk to each other, talk to your population, choose an area to go at and give your integrated neighbourhood team something to start with. Otherwise, you'll just be floundering, talking about funding and form and governance and roles without anything to do.
So that's back to your slide earlier, isn't it, about what's your focus together, rather than how are we going to rally around to do this?
And what's your focus isn't just about what your priority is, it's what in the areas that you're struggling with, you're struggling to deliver care, patients and carers and populations are struggling to get the care they want. What are those areas that lend themselves most to a multidisciplinary team that's going to look after a group of people together? Because I think that's what an integrated neighbourhood team is, isn't it? It's a multidisciplinary team of people. So that's the thing that we've been given. That's our Christmas present. What are you going to use it for?
So
it's the wrong way round, but that's what we've got.
Yeah, and I want to ask people who are on the call that work in PCNs, lead PCNs, either clinical director roles or supporting them. It's my sense that you spent the last 12 months looking all around access. As I said earlier, your capacity access and improvement plan was all around digital access. There was very little around managing the long-term care and conditions of your population. So it'd be really good if there is somebody in a PCN role can come forward and just give us a bit of an insight into how you have these conversations as networks with your practices, or are they not happening? Are you still very much leaving, you know, the core format of long-term condition management to practices, and as PCNs thinking about different service provision? Gosh,
do pop something in the chat. If
please do.
Out, it's not a problem.
Please do. Or even if you want to go away and have a conversation with the other people in your practice network and drop us a line afterwards, we're more than happy to chew the fat on that one. Here we go. Michael again. Thank you, Michael.
Well, you're welcome. And just to put words to what I'm thinking, I mean, Steve, I hope I'm not picking up the wrong end of the stick here, but you talk about your grid in the context of population health, and I understand why you're using that term. Will asked a really cool question in the chat about when does the ICS mobilize, and what does the ICS mobilize on, if you like, at a macro mission level versus what general practice and PCNs mobilize on. I gave an example of Somerset there about the whole system went, oh my God, this is me doing a Somerset accent. Oh my God, blood pressure will kill way too many people and make them end up in hospital with strokes. We should do something together. Cheekily, if I was to critique your grid, I would say it's a practice list management service rather than, if you like, a population health service, though it absolutely uses the good principles of population health, but you're focused on the patient list that sits in the holy duty sacred kind of ownership of general practice. And that's absolutely cool. That's absolutely spot on. Like, you can't do population health without great general practice, but you probably can't deliver it without the help of your friends and allies in the other sectors as well. Does that stream of philosophy make sense?
It does make sense. And sometimes the way I describe things isn't quite right and it's great to get the the challenge. So the grid is meant to be a population. It's just that I've got the data from general practice, because at the moment that's the only place you can get that sort of data from. Ideally, you'd have a patient level linked data set, and you'd have data from the local authority, which would include people who aren't registered with a general practice. You'd have data about assisted bin collection, free school meals. You'd have data from the prison service, criminal justice. You'd have data from hospitals, community trust, mental health trust, etc. The grid is meant to be a community, not a general practice. And the service deliveries are absolutely meant to be, although I maybe didn't describe them as such, services that meet the need of that population group. So when you look at primary prevention, a lot of that is organised outside of general practice. You know, not all of it is delivered in general practice. A lot of family planning is delivered elsewhere. A lot of stuff is delivered in community pharmacies, as you said. A lot of stuff is delivered in dementia cafes and in a park run. So I really mean it when I say I don't care who delivers the care, so long as it meets the needs of the individual. I mean, hypertension is a great example, and I was involved in that work in Somerset, or was it Dorset? I think it was Dorset, actually, the bit I was involved in, and it's good, but I suppose it's a question of is your focus about primary prevention and case finding? Are you trying to find people who've got high blood pressure who haven't been identified before, or are you managing hypertension better? Also important wherever it's managed. But in that regard, if you've got somebody who's got high blood pressure, they've probably got obesity, they've probably got pre-diabetes, they're probably inactive, they might smoke. You're not going to meet the needs of that individual with just a blood pressure management intervention, which is why you need Slimming World and you need Park Run and you need relationship counselling and psychological services. So we've got to be holistic, whereas a lot of clinicians will think diabetes, hypertension, and I think we probably do our patients a disservice when we take a single disease approach. Although in terms of case finding, that's reasonable. Tim.
And Steve, I was just going to pick up on that, because I think one of the challenges is, and you know, certainly the conversations that we sometimes hear back from colleagues in primary care is case finding is great and creating more activity, but I think that there is a concern that sits back at base that, well, it just means more work for won't work for me. And I know sort of the kind of one of the challenges around things like Pharmacy First and how that gets embedded. So hugely successful doing elements, but again, the concern is, the worry is we're going to end up with more cake, and we've got plenty at the moment. So how do we kind of square it? And I think the great challenge at the moment is exactly as you say, around trying to find that singular focus. So trying to understand how you could almost manage some of your demand profile, the activity that's coming into your practice, potentially look at managing it differently, and particularly using your own in-house data, your ability to segment your population, understand who needs what. But I think that it's a journey that we all have to go on in primary care, around understanding that the role might look different to how it would do. That kind of traditional view of anyone comes in and sits in front of you, it might look different moving forwards. And I recognise that causes tension. And certainly in conversations I've had with colleagues, it's something about that, I guess, lack of clarity about what my role is as a GP of 2024 versus GP of 1984, and how do we square that together?
And I think, again, that's where we need to take a patient need first approach. I recognise that it's important that people get trained, and it's important people get job satisfaction, but you can't start there. You can't start with saying, well, general practice is about every GP knowing all of their patients all the time and doing a little bit of everything. You can't start with that. You have to start with, we've got this population with these sorts of needs. This is the myriad of activities that we've got that could support those people. And if we're taking a GP perspective, where are GPs, because, and I'm saying this as a GP, you're a GP, Tim, sorry, Michael, but I'm just using that as an example of what I know best. What are GPs best at? And I think we're best at dealing with undifferentiated demand in acute situations, because we can recognise somatization, we can manage risk, and I think we're quite good diagnosticians. So I think I would have lots of GPs on the front door of acute care in 111 and 999 and on the phone and seeing people face-to-face in general practice. And I think we're quite good at dealing with complexity, people with complex needs. But I would probably keep us away in the main from long-term condition management and primary prevention, because I think others do it a lot better. I mean, I'm being purposefully controversial, but we're good at some things, but nobody's good at everything. So we need, I think we have to let go of that traditional model of, corner shop, general practice, everybody in your local community, and you manage all their needs from prevention through to complex needs management and end of life, because I don't think that works. In a sort of division of labour is important, which I think started with Plato before Adam Smith. So it's I think it's pretty fundamental that different people are good at different things. Let's allow them to do more of what they're good at.
And I think just building on that, Steve, I think one of the great successes certainly that I would see of PCNs, and it's probably in part the way the funding was kind of mobilised, but actually it's brought a whole host of fantastic MDT sort of into primary care, because of the way the funding mechanisms were. And certainly I'm very blessed in my practice to have a good squad of physios, pharmacists, people that can really pick that up, social prescribers who are far better at mobilising the community assets for people. So I think in some senses we're at a really good position where we are sort of year 6 of the PCN DES to actually think, where do we go to the next phase of what we do with our whole team. But I do think, coming back to your main point, that I think it requires a really deep understanding about population activity, who needs what, and perhaps accepting that uncomfortable truth that people do need slightly different elements of care depending on their need, which certainly when we've had conversations with our patient group, as an example, that's something that can be quite a challenging conversation, because actually there's a there's an expectation that everyone gets everything, which is obviously a great place to start off. But actually, I think we're all in agreement that there are some people that will naturally need a bit more than others because of their own long-term conditions, their own risk, and how we want to safely and effectively manage that.
Yeah, and they'll get different things as well as different amount, won't they? My sister's going to see a first contact physio next week, and she's got quite complex things going on, but I suggested to her with a shoulder problem, probably going straight to a first contact physio was the best thing to do, and she agreed with that, and there's I mean, I don't know how I would manage anymore without our physios and mental health workers and clinical pharmacists, but I do think we've gone very far without starting with, okay, well, how are we going to use our first contact physios? Are we going to use them in picking off people from the triage list? Are we going to send people with an acute lower back pain to them? Or are we going to just keep them for sort of patients a week or two later? You know what I mean? And that requires a fundamental thinking. Are they part of the acute care team? Are they mainly chronic care, delivery? Are they a bit of each? But it takes some thinking and social prescribing. What sort of need do we want them to go after? I don't think we've done enough of that thinking yet. I don't know whether that's unfair.
I suspect it probably plays to the challenge we're in at the moment, Steve. I think a lot of us are sort of waiting for what the next sort of marching orders are, and that's sort of everyone waiting for that on the horizon. So again, I think we will hear more about what that starts to look and feel like in the new year. But I guess my encouragement to people would always be to start thinking about what is practicable and doable now. You've got your patient list, you've got your activity data, you know what comes in and comes to see you, you know what your stresses are at a practice and PCN or ICB level, and it's starting to think how can we manage things appropriately and differently. That would be my kind of reflections, I think.
And I think working out where the forums are, where your local discussion groups are, where you can all go to catch up, and we're never short of ideas across primary care and community care and community pharmacy, but what we are short of is places to share information really quickly, and we're very good at reinventing the wheel in the NHS. We need to get better at sharing stuff in a place so that people can learn from each other. Well, that was fascinating. Thank you both very much, and Michael, thank you also for your contributions. So I've popped some links in the chat there. As I said, this is the first of a few sessions. We will be coming on again towards the end of the session with Sabera to look at how to deliver long-term condition care very differently in group settings, and also with your additional roles there. And we've got some other product suppliers coming on over the next few months to share some of how their systems can help support you. So I'm going to finish on time, if that's okay with everybody. Go and have a walk around the block, do a park run or whatever you need to do before you start seeing patients. But thank you very much for your time. I really enjoyed that. We'll be in touch. Thank you.
Thank you, Lisa. Thanks,
Lisa.
Good to see you, Michael.
Thanks, Dave.
Bye. Bye all. Bye.